Welcome back to PACHA's, what are we, 70th meeting? 76th meeting of the full council. At this point, we're going to enter into our public comment. Those of you who are in the room and online, thanks for giving us an additional few minutes as we took a quick break. And with that, for the public comment, I'm going to turn it over to Kay Hayes in a moment, but also just to remind folks, if you want to submit written comments, you are welcome to do so. We will continue to take those comments until April 5th at the close of business, and you can send any comments you want via email to PACHA@HHS.gov. That's PACHA at HHS.gov. And with that, hey, I'll turn it over to you.
Great. Thanks, John. As a reminder, I will call your name, and if you'll please introduce yourself and provide your comments. Our first public commenter is Shakina Rose.
Thank you. Hi, everyone. It's a real pleasure to be here. My name's Shakina Rose, positive Trans National Advisory Board member. I use pronouns they, them. I'm an elder, transgender, non-binary woman living, surviving, thriving with HIV/AIDS for 38 years. Black trans women face the highest rates of homicide and acquired HIV diagnosis. Do you feel this? Black trans lives matter. Sex workers' lives matter. People who inject drugs' lives matter. Human sexually trafficked lives matter. Trans HIV immigrants' lives matter. What's the intersectionality? Molecular HIV surveillance. Last Friday, I organized a national HIV transgender, gender nonconforming group. Everyone was a provider in HIV prevention, gender affirming healthcare and support, harm reductionist advocates, and people who are of trans and gender nonconforming experience. Sexual health education is key to empowering trans youth to begin their lives learning how to become proactive in their sexual health education. Youth need to be educated about drugs and how to use them safely. We need more funding for residential treatment that are safe places for people to recover. Youth trans men need education on their bodies and reproductive health. What does pregnancy look like? What is consent? What is boundaries with partners? Body autonomy. Youth can't get gendered correctly. With current anti-trans bills and laws aimed at trans youth transitioning, we are creating for child refugees across America in 2023. Providing trans youth the tools to succeed is our responsibility. Let us be the solution, not the problem. We advocate for youth, HIV, and STI prevention education be brought back in schools. If you're diagnosed, educate what to do next. Are providers sharing why they are collecting SOGI data with their patients? How is our data being used and how is it being stored? Who has access to our SOGI data outside of our provider's office? Currently, there's no money available for data infrastructure. We need a trans person reviewing the processing of SOGI data in any organization. We need to have we need to hold big pharma accountable, folks. That's the big line. I'm a part of the Rust Belt CFAR Sex and Gender Advisory scientific working group, and we're finding that we're doing a lot of great work there, but the one thing that we're not doing is creating the opportunity for for cisgender women, trans women and men to be researched. We need clinical drug trial programs. Trans men are hurting right now. We talk about choices and options. Have a look at what they are for trans men. As an elder transgender woman, I can't begin to share how disgusted I am about having to go into aged care. We know what it's like in the general population. I'm terrified. Between my HIV/AIDS diagnosis, physical disabilities, mental health challenges, we talk about biases, stigma, and discrimination, add transphobia, hate. How this is supposed to be the time of our lives. I see suicide happening a lot. Who wants that? Who deserves that? We need dignity and respect. We need to uproot and change aged care.
Ms. Rose.
We need to be able to.
Critical comments, but I do want to be respectful for everyone that has signed up in the time allotted. We urge you to continue to provide written comment if you have not finished all of your comments here with us, because we do want to hear those and read those at another time. Do appreciate you providing your public comment today.
Thank you so much for the opportunity today.
Sure. Thank you. Our next public comment is from Douglas Rose.
Another Rose, right? Hi, everyone. My name is Doug Rose. I'm a longtime HIV/AIDS advocate from Baltimore. I've worked on, closer to the mic. Okay, sure. I have worked on state, local, and national programs for the last 30 years, and I'm tired. But the work goes on, and I'm so often called back to it, and I'm being called back to it now, especially regarding molecular HIV surveillance, which just has a terrible ick factor. I mean, let's just put it out there. Who wants to go to the doctor, give them some blood? The doctor says, oh, well, we're going to check to see what kind of medication you need. What you don't know is that that blood goes to a lab, which sends the results to the health department, which uses information from that lab report to try to find other people in your circle who may be carrying the same HIV as you are. And you don't know anything about it, right? Already, it's a huge problem. We shouldn't be taking people's bodily fluids and doing what we want with them. And the health department really doesn't have the right to order whatever they want and do whatever they want with it. That's my blood. That is my blood. And if any of you have had a test in the last year, which I'm betting many of you have not, your blood is handled in the same way. 20 years ago, the CDC came out with recommendations that doctors routinely give HIV tests to all patients between 13 years old and 64 years old. If they had done that, we might not be in the mess we're in now. So now we're looking for ways to skirt around things like partner notification and skirt around people who don't want to tell on their friends and dig around in the dark to find out who might have HIV and who they might be sharing it with. It's really gross. I noticed, oh, sorry, 1 minute. Okay, quickly. I'm really disappointed at the CDC's response to the recommendations that you all made. That response was weak. The community has been at the CDC's door for months now, asking them to respond to it. They didn't even bother to send anyone today. They handed that task over to Harold. That doesn't make any sense. And what the news he had to deliver was, thanks for your recommendations. We're not doing any of that. These are the things we're going to do. And it has nothing to do with what you recommended. And I feel like the response here has been like, oh, well, what can we do? The CDC says they can't do that. What do you mean? You know, I hear people say criminalization. We can't advocate around criminalization. Oh, I'm out of time. I find the same thing at the state level. The health department tells me, oh, we can't do anything about criminalization. All we can do is keep collecting data and databasing it. But that database is subject to criminal investigation. We got to change that. We've got to change a lot about this stuff. I will send you the rest in writing, but I really hope that this group gets some cojones and goes back to the CDC and says, wait, you know, we are making this recommendation. You don't have to follow it, but we may talk to the boss man about that and see where that goes. So anyhow, those are my thoughts. Thanks.
Thank you for your comment. Our next public comment is from Admir Sahija.
Hi, thank you all. My name is Amir Sadahi. I use he, him pronouns. I'm the National Policy and Partner Strategist with CHLP. CHLP is an abolitionist legal and policy organization fighting to end the stigma, discrimination, and violence towards our communities experiencing racial oppression, patriarchal violence, and/or economic divestment. Our work is centered in communities living with and affected by HIV and other stigmatized health conditions. Over the last several years, people living with HIV, organizations made up of and representing people living with HIV, and human rights activists have sounded the alarm about molecular HIV surveillance. There is little daylight between the views of essentially every national HIV advocacy organization. We all believe mandating MHS for every state and jurisdiction without first protecting public health data from being accessed by law enforcement or immigration enforcement represents a dangerous subversion in public health. CDC's guidelines and new assessment tools make it clear that molecular data and other medical information can only be protected, quote, except where the release is required by local and state laws. Many state laws expressly permit and even force health departments to share data with police and prosecutors. On the state level, privacy protections that exist usually always include carve-outs for law enforcement. Public health can't exist if people are criminalized for their health status and if their medical information can be used in those prosecutions. People living with HIV are violently and broadly criminalized in a majority of US states. That isn't an abstract fact. Any discussion of MHS that doesn't start from that premise is fundamentally flawed. Collecting data without protecting it first is just giving law enforcement an incentive to use it against our communities. HHS and OIDP recently proposed creating a federal database, including medical records, to track up to 200,000 low-income PrEP users. A new Oklahoma law establishes a database to surveil patients' medical health information. In Texas, the Attorney General sought access to state driver's license data in an effort to hunt down transgender residents. Surveillance and approaches that dehumanize us are on the rise. Approaches that potentially hand over our information to police and prosecutors are on the rise. They all, including molecular HIV surveillance, threaten the health outcomes of our communities. The CDC, ONAP, and PACHA must work together to ensure that any further implementation of MHS is conditioned on firewalls prohibiting any and all public health data from being accessed or used by police, prosecutors, and immigration enforcement. And the last thing I'll say is please, 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 any future meetings between PACHA and CDC about implementing the MHS resolution, please let them be accessible to the public. Thank you.
Thank you so much. Our next public comment is from Benjamin Brooks.
Hello, thank you so much. My name is Benjamin Brooks, and I use he, him pronouns. I am the Associate Director of Policy and Education with Whitman Walker Health in Washington, D.C. Women Walker was founded 50 years ago this year in 1973 as a place for gay and bisexual men to go and find the care that they need to keep each other safe. Like many other FQHCs, we consider ourselves to be partners with everyone in the room in advancing the health of our minority communities and our particular needs. I'm also have the pleasure of serving as a co-chair of the AIDS United Molecular HIV Surveillance Committee, along with many of the folks in this room. We've raised the issues around privacy and confidentiality and consent with molecular HIV surveillance. I want to pause because I think that point has been really made here. I want to say that on behalf of community health centers, we are working so hard with you to address the syndemic of COVID-19, HIV, Mpox, chlamydia, gonorrhea, syphilis, right? And I want us to take a second because I think we're all aligned in this room to recognize that we're addressing many different indicators of a root cause of structural racism in the room. And I want to point to the key structuring force that we found in a research project that we did along with HIPS, another HIV serving provider here in DC, and Georgetown's O'Neill Institute, that criminalization is the #1 cause of harm and marginalization and stigma for these communities, in particular, communities that we research as people who are engaged in sex work, inclusive of and really focused on transgender women of color and Black gay men. So please, I hope that we can reach a consensus on decriminalization of sex work, decriminalization of poverty, and decriminalization of those things that I am contractually obligated to not talk about because of the contracts that my healthcare center has with the NIH and the HHS, which severely implicates our ability and our moral capacity to advocate on behalf of our patients. So this is a weakness that is structural and based, I think, deeply implicated in our racist history as a country. I want to add as well that we are furiously working towards SOGI data inclusion across HHS and the US Census. We are working to expand access to LGBTQI culturally competent education for healthcare providers so that when patients go to their healthcare centers, they can get the care that they need because they have safety to disclose who they really are and what their needs are, and that we are in the States fighting back against attacks on gender-affirming care for our transgender kids and their families. So FQHCs across the country are doing these things. It isn't just Whitman Walker, although we are working to be a leader in this space. So FQHCs need your help. We are under-resourced and not provided the staff or the money to do this work. We were doing it on our own free will and because it's at the heart of our mission. So we're honored to be your partner, and we're asking for more support, more communication, and more connection around these issues. Thank you so much for your time.
Thank you. Our next public comment is for Leanne Sanchez. And our PACE Officer Lieutenant Commander Rodrigo Chavez will be translating.
Hello, everybody. I just wanted to... Lian, soy Rodrigo, nada más quería decirte que me dieras frases cortas para traducir y luego así no nos empalmamos, ¿ok? Bye.
¿Va a ser la interpretación simultánea o va a ser consecutiva?
Consecutiva. No tenemos equipo para simultánea.
Ok, consecutivo sería ¿cuánto tiempo?
Dame una frase cuando sientas cómoda.
Sí, pero consecutivo.
3, 4 oraciones.
Ajá, quiero
Okay, she's asking me if there's going to be a little bit of more time allowed because of the consecutive translation, and because that would limit her time.
Oh, okay.
Absolutely, we can continue and proceed.
Sí.
Gracias. Bueno, buenas tardes. Mi nombre es Lian Antonio Sánchez. Lidero una organización que es Community Estrella en algunos estados del Deep South.
Good afternoon. My name is Lian Antonio Sanchez. I am the leader for an organization that provides services in some states of the Deep South. Adelante.
Estamos basadas en Georgia. Nos dedicamos a defender, movilizar y empoderar a nuestra comunidad LGBT, particularmente a las personas translatinas, inmigrantes y monolingües.
We provide advocacy. We defend all the communities of Latin communities from the areas of the South.
Como verán, represento diversas intersecciones.
I represent the diverse spectrum of intersections.
Y la cual sí tengo varias preguntas porque yo no veo comunidades incluidas en esta mesa de concilio.
I do have a few questions because I don't see the diversity represented in this council table.
Particularmente a las personas latinas o indígenas latinoamericanas.
Particularly those Latin communities or indigenous communities.
Porque lo que hemos observado en las estadísticas es que nada más a las personas indígenas piensan que son indias nativas americanas.
Because unfortunately what we've experienced is that only Native Americans are the ones that are being considered and defined as Aboriginal or Indian populations.
Y no consideran a nuestra comunidad indígena latinoamericana.
And our population of Latin American indigenous populations are not being taken into consideration.
A su vez también en las estadísticas todavía seguimos siendo contadas como hombres teniendo sexo con hombres en cuanto a mi identidad trans.
And at the same time, we, as far as the statistics go, we're still being considered as males having sex with males and denying my identity as a trans person.
Y esto impacta también en ciertas clínicas y hospitales donde proveen servicio.
And this has an impact on clinics and hospitals where their services are provided.
Muchos de nosotros como personas inmigrantes latinas indocumentadas en algunos estados no tenemos acceso a un cambio de nombre o un marcador de género.
And we do not have access to a way of changing the sex or gender marker whenever we receive the services.
Y sufrimos una doble o triple discriminación.
And therefore we're victims of double or triple discrimination.
Inclusive cuando yo estuve también en la cárcel de inmigración, yo veía que no daban tratamientos de VIH.
To include that when I was incarcerated in an immigration detention center, they wouldn't provide treatment for HIV.
A todas las personas que tenían que viven con VIH, los ponen en confinamiento solitario, en un hoyo oscuro, como celdas de castigo.
Of all individuals living with HIV, they put them in areas, in dark cells where they're pretty much sent there as punishment for their condition.
En condiciones insalubres e inhumanas.
They were put under unhealthy and inhuman conditions.
¿Cómo van a poder obtener o adquirir un servicio de salud integral?
How are they going to be able to get a comprehensive health service?
Y si también nosotros como personas inmigrantes indocumentadas es muy difícil de acceder y por eso nos refugiamos en las clínicas y hospitales privadas.
That's why as undocumented individuals, we seek refuge and help in public clinics.
Private clinics. Clínicas privadas.
Oh, private clinics.
Y esos resultan muy costosos.
Those services are very expensive.
Y con esto como consecuencia,
and as a consequence of this,
solamente nada más venimos para trabajar y pagar por un servicio de salud que debería de ser asequible para todos, sin importar el estatus inmigratorio.
Therefore, we only come here to work, and we do not have access to services that should be accessible to us without regard to our immigration status.
Entonces deberían de enfocarse a una salud integral.
then the focus should be to comprehensive health.
Ahora, actualmente, en Georgia acaba de pasar la SB 140. Increíble.
In Georgia, they just passed the law SB 40, incredibly.
SB 140.
SB 140.
¿Cómo es posible que nuestro propio gobernador, que nuestros propios legisladores nos estén usando como carnadas políticas a nuestras identidades trans y particularmente metiéndose con nuestros niños?
How is it possible that for our governor and the state, they're using it as political bait and even getting into affecting our children's livelihood?
Cuando ustedes han invertido fondos para proteger a niñas.
Whenever, considering that you have already invested funding to protect our children.
Y no lo están haciendo porque discriminarán a un grupo de personas.
And it's not being done because they are discriminating a group of people.
A un grupo
Lieutenant
vulnerable que es la
Commander,
comunidad trans.
Chavez, could you please
Yes.
communicate? We'll need to wrap.
Okay.
Thank you. Thank you, Lee.
Gracias.
Thank you so much.
Thank you.
Our next public comment is from Martha Cameron.
Good afternoon, everybody. My name is Martha Cameron, Executive Director of the International Community of Women Living with HIV, and also Vice Chair of the People Living with HIV Caucus. And I would like to start my remarks differently from how I'd written them, and that is by making the statement that I would like it to go on record that any consent that I gave, that I didn't know that I gave unknowingly for MHS or CDR needs to be removed, please, until we can do something effectively to protect the data of us people living with HIV. Thank you. And now I'll move on to my remarks. My first remarks are to do with the breast and chest feeding guidelines, which we applauded that they were finally changed to be able to at least allow women living with HIV to be able to breastfeed after receiving proper guidance and counseling, and also making sure that they are virally suppressed. The updated guidelines also give really good information about the benefits of breastfeeding, which haven't really been shared. A formula is essentially forced on people who are breastfeeding and people living with HIV. And then the other thing is that it also has a lot more equity considerations to address the effects of structural racism, which has been talked about today, poverty and segregation, and also has inclusive language and guidance for transgender and gender diverse populations, including the fact that we're saying breast and chest feeding. I think what I'm here to ask for is that we don't really seem to see these guidelines translating into the community. I think it's not automatic that just because we have updated guidelines that providers who treat women living with HIV are informed, that organizations, including obviously Ryan White and Medicaid, which provides the majority of services for people living with HIV, have been advised to provide additional services and peer navigation and just education for women living with HIV. And also one of the things that these guidelines included was the fact that CPS, Child Protective Services, should not be called. I don't know if you're aware that they were being called when a woman chose or asked to breastfeed, because that would be endangering the life of her child. And we don't know whether they have been informed, and people are still reporting being harassed in this way. So, it would be difficult to try and advise a CPS worker to read the guidelines as they're taking your child away. So, we want to ensure that there is education provided for providers. I myself gave birth. He's now 12 years old. And I was receiving Ryan White care at that time, but I was moved into Medicaid as a pregnant woman to be able to receive services. And my child was also immediately covered by Medicaid. But the OBGYN provider very explicitly told me that I had no business having children as an HIV positive woman, and offered to tie my tubes immediately after I'd had the baby. You have no idea the amount of stigma and discrimination women, and especially Black women or women of color, that are just accessing basic human rights and simple reproductive services, the stigma that they go through. And this is heightened 100% for transgender and gender non-conforming folks. So imagine a trans man who chooses to use his right to carry if they still have ovaries, they will be treated in the most horrific and discriminating way. So we want to make sure that not only is there education, but there's guidelines and safety for people who choose to still receive these services. It's not enough that the guidelines have been changed. The last thing I'll quickly say is also, especially as a representative of the caucus and the advocacy that we did around the quality of life indicators that we're so grateful ended up appearing in the National HIV/AIDS strategy, is that as of now, we really have no framework to monitor what is going on with the indicators that were put in, and whether, first of all, agencies are responding to this in a way that they should be. For example, issues of mental health and employment. We would love to see the Department of Labor and SAMHSA actually share with us what is being done to address some of the baseline indicators that were put in the National HIV/AIDS strategy. We know, for example, that HRSA is responding to this. I myself was invited to an expert panel on quality of life, but we have really not been engaged as the community to help put together, or at least help monitor, the framework in which these indicators are going to be implemented. And I would love for this group to help us really ensure that community continues to be involved, because quality of life is about people already living and aging with HIV. All I've heard today, which is great, about ending the epidemic and PrEP and everything, is really great, but there's still going to be people living with HIV, even if we end the epidemic tomorrow. Thank you.
Thank you so much. Our next public comment is virtual. I have Hermione Bell. Hermione, thank you.
Good afternoon. Can you hear me?
Great, thank you.
Hello, everyone. My name is Hermione Bell, and I'm a nurse practitioner in Atlanta, Georgia. I have been providing care to people living with and vulnerable to acquiring HIV since the epidemic was identified. I recognized early on that HIV was not just an illness that affected white gay men, but affected anyone who was sexually active, regardless of ethnicity, gender, identity, or sexual orientation. I didn't have the language or the words to describe the care I was providing in the early days of the epidemic. I only knew that care was needed. I knew that I was vulnerable to acquiring HIV because of my sexual behaviors, even though the information available in the early 1980s said HIV affected white gay men and people who injected drugs. I questioned that narrative early on because I didn't think it didn't make sense to me. I didn't understand how it only affected certain groups of people if we all, as human beings, have blood in our bodies. Therefore, I consumed as much information as I could to help myself, family, friends, and patients understand their vulnerability to acquiring HIV. As an African-American woman, my appearance is classified as being a minority in this world, being Black and being a woman. I actually identify with two other minority groups that are not seen when you first meet me. I am left-handed in a right-handed world, and I am proud to represent the B in the LGBTQIA+ community. My very being shows the intersectionality of humanity that is often overlooked or unseen by those who know better, but continue to not do better. We have come a long way in the 40+ years of the HIV epidemic, but we still have a long road ahead of us if we do not address the epidemic in Black women, Black heterosexual men, and trans men. Yes, Black women are on your radar, but a lot of the programs, research, funding, and current strategies, we still focus primarily on men who have sex with men. I have practiced in private and public health settings in Atlanta, Georgia for the past 35 years. I will be relocating to Houston, Texas area later this year and will continue to provide care to those living with and vulnerable to acquiring HIV. I'm an active member of the Metropolitan Atlanta HIV Services Planning Council and applaud our council on the work that has been done serving the 20-county EMA. However, we need to look at how funding is allocated in our community. We need to fund services and not agencies. For example, I have a patient who needs dental care, but is denied this service because he does not receive his primary care at a Ryan White funded agency that has a dental clinic. This Ryan White funded dental clinic still does not meet the standard set by HRSA for oral health, even when this service is available to the patients in their own program. Additionally, I have a patient who needs housing assistance, but she cannot receive assistance from an agency that receives HOPWA funding because she does not receive her primary care there. They are both eligible for services based on eligibility guidelines for Ryan White, EHE, and HOPWA, yet they are unable to access these services because they want to keep me as their healthcare provider. They are told that they must change their healthcare provider to receive the service. This is a barrier. Fund services and not agencies. We also need education for healthcare providers outside of Ryan White, EHE, and funded providers. Educating primary care providers, GYN, OB, urologists, and others who take care of people. It infuriates me that some providers that specialize in our private body parts don't know or don't want to know about PrEP or PEP. Part of our responsibility as a healthcare provider is to educate our patients about their health conditions, but it is also our responsibility to educate other providers about HIV care, treatment, and prevention. Not only are our patients aging with HIV, but the providers are aging too. I am 61 years old and I am planning to retire in about 9 years. Throughout my career, I have served as
Ms.
a preceptor. Yes.
I'm so sorry. We've exceeded the time here. I certainly encourage you if you want to provide the rest of your written comments so that we can have that. And thank you so much.
You're welcome. Thank you.
For our virtual presenters, I've been notified that you cannot see the timer. Just as a reminder, it is a 3-minute public comment. We have been a little lenient because we wanted to make sure we get some comments in, but I do want to be respectful for those folks that have pre-registered for public comment. Our next comment is from Sierra Coven. Sierra, the floor is yours.
Okay. Hello, everyone.
Hello.
My name is Sierra CC Coven. I'm here today as a woman living with HIV and as a representative of so many other women in this country in a nonprofit organization, The Well Project. As many of us in the HIV community, and thank you, Martha, for introducing us, know that on January 31st, 2023, the recommendations for the use of antiretroviral drugs during pregnancy and interventions to reduce perinatal HIV transmission in the United States, or better known as the Perinatal HIV Clinical Guidelines issued by the U.S. Department of Health and Human Services, were updated and included some very big changes to the section on infant feeding for individuals living with HIV in the United States. These updates are a step in the right direction for the guidance that is given to women and other birthing people living with HIV in the U.S. This could not have happened without the united and uplifted voices of those in the community. One extremely important change was the addition of a statement that says that child protective services or similar agencies should not be engaged in response to infant feeding choices made by women and other birthing parents while living with HIV. Parents who consider breast and chest feeding in the U.S. have too frequently been considered a threat to their children just to the fact that they are living with HIV. From my own personal experience, I know that this threat is one of the scariest, and by removing it, pregnant people living with HIV will have more confidence to exert agency over their bodies and how they care for their families. As a mother living with HIV who has given birth to 2 children and had the resources and support to breastfeed my second child, I often feel that I'm in a place of privilege because of my proximity and access to these extremely vital means. While I'm grateful for my experience, privilege shouldn't dictate access. Breast and chest feeding, while a complex issue, is considered both the healthiest option for infant feeding for the general population and the standard of care for women and other birthing parents living with HIV in resource-limited settings globally. It is the limited research on breastfeeding and HIV in high-resource settings that has resulted in a lack of education and clinical standards for providers in these areas to support women living with HIV and making more informed infant feeding decisions. We're gratified by the updates to the perinatal HIV clinical guidelines. The work is not done. It is important that we continue to arm our diverse intersecting communities with the new information contained in these guidelines and provide them with tools to engage in shared decision making. This will be much easier to achieve when there is concrete research that is dedicated to breast and chest feeding among women and other birthing people in the United States, a high resource country whose guidelines are often referenced throughout the world. On behalf of myself and the Well Project, I'm here to propose that PACHA advocate for the following: dedicated research funding to understand the dynamics and experiences around breast and chest feeding by parents living with HIV in the U.S., a commitment that the guideline changes can be disseminated, addressed, and implemented across all federal agencies, the National HIV/AIDS Strategy, and the EHE plans to better serve women and other birthing people living with HIV, and the development of tools that encourage providers to engage in practices centering people living with HIV versus a dynamic that too frequently threatens the bodily autonomy of those receiving care because of their HIV status.
Thank you so much. Our next virtual comment is from Juan Esparza. All right, Juan Esparza. Our next public comment is from Demarie Rivera. Demarie Rivera. We have another virtual comment from Mark Mizrock. Mark Mizrock. We have our next virtual.
Thank you so much.
Marcus. Oh, great, Mark. Thank you. You have the floor.
I'm Mark Misrock. I use he and they pronouns, and I'm the executive director for the National Working Positive Coalition, a long-term HIV survivor and a member of the steering committee for the U.S. People Living with HIV Caucus. And I hereby revoke consent for the sharing of my health information related to my HIV diagnosis, genotyping, or any other related information. The National Working Positive Coalition is focused to strengthen responses to the long ignored employment needs of people living with or at greater vulnerability to HIV. In past PACHA meetings, I've shared information with this council from the CDC's most recent annual reports from their MMP or Medical Monitoring Project, reporting on their data collected through structured interviews with people living with HIV for 2019 and 2020. In the 2020 report, the data showed over 40% of people living with HIV as unemployed, with 35% reported as living in poverty. Are we comfortable with these data? Just last week, hundreds of people living with HIV and advocacy allies convened for the AIDS Watch meetings and Hill visits. Across 3 days of AIDS Watch, I was astounded how many of some of the most resourceful people living with HIV from all over the country grabbed me to ask for information related to working and employment-related services, and were struggling for lack of assistance from HIV service providers with this primary social determinant of health. I have made public comment to this council on behalf of the National Working Positive Coalition before, and will keep coming back. as long as there is no, I'll keep coming back as long as there's no effective efforts from the HIV/AIDS Bureau to connect Ryan White HIV/AIDS program participants with the information, services, and resources needed to navigate achievement of well-informed and self-chosen goals for employment and out of enforced poverty. I will keep coming back as long as the CDC acknowledges the powerful influence of social determinants of health, including employment, on vulnerability to acquiring HIV and other health risks, but does not take action to intervene in the economic and employment struggles of those confronting severe health inequities. I will keep coming back as long as the Department of Labor and the Department of Education are not partnering with HRSA and the CDC in the context of HIV care and prevention, bringing allocation of resources and expertise to address employment needs in communities they've severely underserved up to the present. To close out, I request that this council schedule broader education and information gathering to become more informed about employment needs, strategies, and their importance in the domestic U.S. response, and for development of a resolution calling for substantive action going beyond research and beyond meetings to creating access to the employment-related information, services, and resources that would allow more people living with HIV to escape poverty through participation in employment of their choice, and for a reduction in new HIV acquisition related to poverty, unemployment, and underemployment.
Thank you, Mark. Our next public comment is virtual. Nana Khanna. Nana Khanna.
Yes, thank you. Trying to come off mute. Hello, everyone. I'm Nana Khanna, they or she pronouns with Positive Women's Network in the U.S. People Living with HIV Caucus. I'm a person openly living with HIV, and I hereby revoke consent for the sharing of any health information related to my HIV diagnosis, genotyping, or any other related information. Thank you to the Council for hosting this important meeting and to our federal agency partners. One thing I want to address is that the failure to address the flat funding of Ryan White while extolling funding for the Ending the HIV Epidemic program and the National PrEP program in virtually every presentation today speaks volumes and sends a clear signal about the priority level people living with HIV hold within the domestic HIV response. As we have a growing number of people living with HIV, aging with HIV, with comorbidities and greater need, flat funding is actually a cut, even without considering inflation. The powerful work done by ONAP and federal agencies to attend to things like the quality of life indicators for people living with HIV cannot be accomplished without associated investments. Budgets and agendas show our values. It is not sufficient to tell us that the Ending the Epidemic plan is addressing the needs of people living with HIV better than the Ryan White program, when the EHE itself is actually predicated on violating the human rights of people living with HIV and is utilizing status neutral approaches with no documentation of or required reporting on the impacts of shifts from a status neutral model to units of service provided to people living with HIV. The failure of the EHE panel to address human rights and the structural environment framing the entire response is more than disappointing. It is outrageous. HIV is a virus. The epidemic in the US at this point is minimally about biomedical treatment and healthcare advances. It is about politics, culture, stigma, discrimination, racism, especially anti-Blackness, queerphobia, transphobia, and whose lives are valued. We want to thank the Council for the tremendous body of work on the MHS CDR resolution. Many assertions have been made today in response to the resolution that we encourage PACHA to look into more deeply and to please ask more questions of CDC. With respect to the assertions about the role of MHS in advancing the fight in addressing racial inequities. This is not what we are hearing from public health departments on the ground. We have heard of multiple examples of resources being reallocated away from essential programs, away from essential services that reach the hardest to reach communities, especially BIPOC, queer, and trans folks. With respect to assertions that community engagement and involvement are happening, networks of people living with HIV are demanding structured involvement in these processes, not one-off tokenistic engagement at CDC's discretion about who gets invited to the table. With respect to data protections, it is absolutely unacceptable to just push this responsibility off to the states and to say that CDC has no role in this. CDC, the federal government, and PACHA, as a federal advisory body, must use every lever within your power to ensure consistent and robust data protections, regardless of who people are and where they live. This is one virus. Speakers throughout the day have discussed the dangerous political and cultural moment we are in, the importance of bodily autonomy, protecting human rights, sovereignty, and dignity. I heard a member of the council earlier today ask about internalized stigma. Internalized stigma does not come from somewhere deep within us. It comes from internalizing discrimination and structural violence that exists in systems that must be changed. Dr. Poteet talked to us earlier eloquently about how we must imagine social and political transformation even when it feels impossible. I urge the council and our federal partners that the time is now, not 2024, not 2025, not even tomorrow, to put protections in place and to make hard decisions about shutting down now any forms of data collection and surveillance that place BIPOC, queer, and trans communities in harm's way at a time when attacks on our communities are escalating.
Thank you, Nana. Our next and last comment, virtual, is from Terry Wilder. Terry Wilder.
Hi.
Great,
here.
welcome.
Hi, thank you. And I am not thrilled I had to follow Nana. I'm not sure I'm going to be able to do it with that much passion, but thank you. Hello, my name is Terry Wilder. I use she, her pronouns, and I am the HIV and aging policy advocate at SAGE. SAGE is the world's largest and oldest organization dedicated to improving the lives of LGBTQ+ elders, including older adults with HIV. I'd like to express my gratitude to PACHA for including a discussion around older people living with HIV and long-term survivors during a recent meeting. At SAGE, we've been working on this issue for some time, dating back to when we created the first support group in the country for older people living with HIV. I want to discuss a crucial need regarding the CDC's HIV testing guidance. Specifically, the CDC should remove the upper recommended age limit for HIV testing. The current U.S. Centers for Disease Control and Prevention guidelines state that screening for HIV should be performed routinely for all patients aged 13 to 64. Our goal is to have the upper age limit removed so that all people aged 13 years old and older are included. Despite the fact that many older adults, as well as their providers, don't think that older people are vulnerable to HIV, data from 2020 tells us that approximately 17% of new HIV diagnoses in the United States occurred among people aged 50 and older. Failure to engage adults of all ages in HIV testing undercuts test and treat strategies of prevention and ending the HIV epidemic goals. While the CDC has not recommended routine HIV testing for adults over the age of 64, some experts argue that HIV testing should be a routine part of healthcare for all adults, regardless of age. In November of 2016, New York State passed a public health law 2781-A, which removed the upper age limit for recommended HIV testing. The New York State public health law mandates the offer of HIV testing to all patients aged 13 and older. The 2016 amendment to the New York State public health law removed the previous upper age limit of 64. The offer of HIV testing is most effective when it's presented as a clinical recommendation of the healthcare provider. The offer of HIV testing must be documented in the patient medical record. SAGE would like to see a change, like New York State, made via the CDC guidance to make this change. Pressure from advocates, meeting with CDC leadership, and public comments to the U.S. Preventative Task Force will be required. HRSA should strongly encourage Ryan White recipients to use HIV testing resources to specifically target older adults by ensuring that the planning councils include such testing as a priority and that contracts are secured while the organizations most able to reach these individuals. The CDC and its partner agencies should increase collaboration across HIV service testing networks, the Aging Network, and faith-based community organizations to improve HIV testing rates among older adults. In addition to removing the HIV testing age limit, we must also take additional measures to advance all HIV prevention services among older adults. In conclusion, I respectfully ask that PACHA consider a resolution around the age limit being lifted for HIV testing and that more resources be allocated around HIV prevention for older adults. Thank you for your time and consideration.
Thank you, Terry. Thank you for our public commenters. I will turn the floor back over to John and Marlene.
Great, thank you. And truly thank you to all of you who spoke at public comment. Bringing your wisdom, your lived experience, your data to this table is something we count on and take it seriously. And it's our responsibility to make sure we carefully listen to it and act on it, which is what we do. We will meet to talk about the comments we heard as well and figure out how to move forward. It is not typical for us to comment on any individual given sort of responses right away. I do want to just generally say that in terms of the molecular HIV surveillance and the cluster detection piece, that I do appreciate Harold Phillips sort of taking at the highest level of the government, sort of in his role of the domestic AIDS sort of priorities, the sort of leadership to look at this with CDC and across government. That said, we as a council also sort of heard Harold's presentation as you did at the same time. We want to carefully consider what was said. We need time to do that as a council and figure out how we will move forward and how we will actually do that. We did distribute the slides that Harold used to the council today. After his talk, we received them. There are some copies in the back of the presentation as well for folks who would like that. So the council will be sort of considering what we heard and considering your comments as we sort out where we go. And as we also sort of put in context our role, which certainly is to advise on policy, to inform, and do that to the maximum extent that the council certainly feels is needed. So do appreciate the continued information and comments, and just want to reassure folks that we need to absorb this information as well as a council as we continue to move forward on this important issue. And with that, what we would like to do is literally take a 5-minute break so we can set up for the PACHA-to-the-People. And Marlene, do you want to set that up in any way before we go on break?
Yeah, if we can make sure that we do come back truly within 5 minutes. Folks have waited all day, many of which are in the room, and this is really our beloved, cherished time with them to have this exchange. So for this latter part of the day, in keeping with National Women's History Month, I have asked several women on the PACHA Council to help John and I co-facilitate this PACHA-to-the-People session. So Tori Cooper and Dr. Ada Stewart will be truly doing the facilitation. John and I will take as many copious notes as possible, but it is our opportunity to hear back from community, those in the room, and I'm not sure if we have anyone online virtually, but I do want you to take a bit of a break, but please come back 5 minutes sharp. Thank you so much. Back to our next part of the agenda, the PACHA-to-the-People session. So thank you to those of you who are joining us on the line. If you do have a desire to make a comment and chime in, please use the raise hand feature, and we will make sure that we have someone who can identify you and allow you your turn. I will now officially turn this next part of the session over to Tori Cooper, Dr. Ada Stewart.
All
One-
right, all
one-
right.
1 sec. Let's verify. Marlene, can we let me verify? Are we live on the stream? Charles, they will want to make sure.
Yes, we're live.
Okay, thank you. Cool.
Okay, so welcome and good afternoon. So we're here to hear from you all. And so first of all, I'd like to see if anyone has any questions, comments to get things started. If not, we have some that we could throw out there at you all. So community, please speak.
And we also have
Thank you. Thank you. My name is Benjamin, and I'm wondering what is PACHA's plan around the updated recommended guidelines from FDA on blood donation that are more inclusive, if you've got thoughts and ideas around that.
Thank you very much, Benjamin. And will you be able to join us tomorrow? Wonderful. Okay, well, we look forward to seeing your name, if nothing else. Great question. So what other questions do you have? Okay, great. We have an online question as well. So while we're waiting for the person online, we'll have a question from Shakina.
Why is harm reduction capped at 5%?
Why is harm reduction capped at 5%? No higher. Thank you. Arthur? You look beautiful, by the way. Someone said, can you be more specific?
In one of the presentations, and I'm trying to recall which it was, SAMHSA, yeah. Does that help?
Yes, thank you.
Did we needed to?
And for clarity, there may be, some of the folks have already had to leave. Oops. There may be some folks in the room who can respond directly to your question. We have note takers who will write down the questions as well as they can. Some of the things we'll be able to address today. Some will actually come up again tomorrow, and others will get back to you. Or you can certainly follow up with us as well.
I apologize. I missed the first half of your question because I was getting water. So the question was, why is harm reduction capped at 5% for that NOFO? So the reason is because we have a harm reduction NOFO that focuses on harm reduction. This particular NOFO focuses on substance use disorder treatment. So the majority of this particular NOFO is to pay for the treatment services for people who are undergoing substance use disorder treatment. We do have a separate NOFO where 100% of funds pays for harm reduction. It's the harm reduction NOFO. I mentioned it, I think it was the last NOFO that I mentioned in the presentation that was funded in 2022, FY22. So we are, and also the other thing I will say is that substance use disorder treatment facilities oftentimes have harm reduction components within them, and staff time, you know, if we're paying for the staff time and they have a substance or a SSP integrated, we don't pay for the SSP, but the staff might, you know, refer people over to it and things, and they're oftentimes embedded. So I don't know if that answered your question, but the focus of this NOFO is not harm reduction. We do have a NOFO that focuses on that. For the one that I spoke about earlier, yes, so that is specifically a substance use disorder treatment NOFO. The focus of that program is to provide substance use disorder treatment to people at risk for or living with HIV. I agree. And so what I would like to do is I can refer you to SAMHSA's website that sort of discusses harm reduction and what SAMHSA focuses on in much more detail. That also includes the harm reduction services and supplies that we pay for. But also, I agree, like seatbelts are harm reduction, masks are harm reduction. There's like the umbrella of harm reduction is so much larger than just syringes. And so it's also just a philosophy, and that philosophy can be baked into any programming, not just the one that is a harm reduction specific notice of funding opportunity. So I will send you that link that has much more comprehensive information. That's true. Mm-hmm.
And we cannot hear what is being said in the room. If you wouldn't mind handing the person the mic. Thank you.
Sorry.
I apologize. I said that if we were able to, harm reduction is a stigma. There's stigma attached to hearing the word harm reduction. It automatically creates a visual picture of a situation, a person's experience. So if we're able to enlarge the view of how we look at what the word harm reduction is, and, you know, Kirsten gave a lot of good examples of how we could use that. And if people started to identify that, oh, I'm doing harm reduction, it would just flip the stigma and create a positive experience.
Thank you for that, Shakina. And if I may also add, on effectiveinterventions.org, the CDC has behavioral health interventions, which many of which also include harm reduction strategies in them. And most of those are categorized for specific populations, correct? I know TWIST is there, which is for transgender women. It's a new intervention. Certainly something to check out, a little plug there. All right, thank you so much. Effectiveinterventions.org. And then we'll come to you, Martha, after we get them. All right, let's hear from you, Ms. Martha, while we're waiting.
Oh, wait.
Got it?
I am here. Can you hear me?
Yes.
Hey there. So I have a question regarding molecular HIV surveillance. Given the long historical distrust of government and medical experimentation by queer people, trans people, people of color, drug users, and so on, I'm wondering, as molecular HIV surveillance and the awareness surrounding it grows, how can we best keep people in care and not have them avoid getting regular viral loads and resistance tests when they need it? The CDC seems very intent on what they call having a complete data set, but they can never have a complete data set if we run from them. And that would involve a degree of self-harm, of not staying in care because we distrust them. So regardless of where you stand on the issue, I think we all want people to stay in care. So how can we make that happen?
So thank you, Michael. Is that Michael? Yes, and again, we heard what was said earlier today, and PACHA as our group, as we convene, we will be further discussing all of these issues and concerns. And right now, I guess we'll just take it and note it.
And just to affirm what my co-chair, my wise co-chair, Dr. Reisman, shared a minute ago as we transitioned, is that, we heard the feedback to our resolution at the same time you all did, So we are definitely going to have additional conversation about what next steps or actions that we may want to consider as a council. As a reminder to all in the room, this group, this PACHA leadership took community concerns very seriously, continue to do so. It's why we're having this conversation and dialogue at every meeting. It's the idea that we are basing our recommendations that get guided by your voice. So we will continue to uphold that mission. And so just know that there will likely be more from us to come. But just wanted to reassure everyone who has a concern around MHS on the mind that we will take further action as we have always done. Thank you. Yes. So Tori asked, can we share what our PACHA resolution that includes recommendations that we made regarding molecular HIV surveillance and cluster detection and response? Are we able to share it? So yes, the resolution is located on HIV.gov. If you go under the federal response in PACHA, you will see our most recent resolution. If you're in the room today, we have copies of the resolution in the back of the room. So it is widely available. And if you still need it, please reach out to us at PACHA@HHS.gov. But it is on the HIV.gov website under the PACHA page under the tab of federal response.
Thank you, Marlene.
You're
That
welcome.
was very, very helpful.
Yes.
All right. So now we have a question, Ms. Martha. Actually, you can take the microphone. Got it?
Okay. Thank you. And if I can just say, we're really reassured by your leadership and how you respond to our concerns. So, that is very good. What I wanted to talk about is Medicaid and Medicare, specifically as it relates to people living with HIV, which, speaking to the choir, we know over 50% will end up having to access Medicare. And there just doesn't seem to be any proactive sort of planning for this transition. And people who are going through it are getting really like unpleasant surprises about the transition. And so it would really be good to have a conversation to understand what CMS is doing. We know that they serve over half of the HIV population. And this is a challenge, as you've already heard, in places where Medicaid is not expanded. So it's really important as people age to be able to do that. And then I'll just tag on an additional comment. A lot of the things that we talk about, especially in terms of aging, and also issues to do with the young LGBT community, these are things that have already been researched. Like there's a huge body of research by the NIH and the DCC, for which I'm a member of, and we don't really seem to see this research translating into services and policies. And so that is really critical, especially with the aging. Give one teeny example of me as an aging person, not yet 50 almost, but already experiencing menopause. This was discovered already 10 years ago, but somehow my doctor never seemed to know about it and was not able to help me as I've been struggling with issues, as I've been aging earlier than the regular woman would age. And then for policies that are to do with LGBT and the harmful policies that we're hearing about in the different states, if there's already research showing that these policies shouldn't be in place, I don't know why we don't use it. Thank you.
Next online, we have Alexander Garbiera.
Hi, sorry, actually, I was typing my question, but thank you. Reverend Alexander Garbera from New Haven, Connecticut. Two questions. Now that the anchor study clearly shows that treating precancerous lesions greatly reduces the developing anal cancer for men and women with HIV, is there any suggestions that HRSA will develop performance measures for anal cancer screenings similar to cervical cancer screenings? That's one question. And the other question is about the meeting tomorrow. I think I was confused about public comment and pre-registering or something. So I'm not sure about the proper procedure for these kind of meetings, but it was a little confusing. So.
Thank you so much. Public comment is just a clarifying. This is Caroline Talib, but a clarifying point. Public comment is where any federal advisory committee has the opportunity to hear from public, and that's a statement. And then this PACHA has implemented these community engagement sessions that are more interactive. And so you're perfectly fine. I will say, if you had a statement you want to share with PACHA in addition to what we're talking about now, you have until next week, and you can email me your statement, and we'll make sure it's in the minutes. And that's at PACHA@HHS.gov, and you can find it on the agenda. So just in terms of clarifying, and I'll pass it back over to our facilitators.
Okay. Hi, everybody. Thank you. Yes, my name is Amir from CHLP. I just have two questions. The first, I really, just like all of you, appreciated that panel on stigma. That was a very, very great panel. And one of the themes of that conversation was about the role of medical providers in a public health effort. And something that we at CHLP have been asking for years, and we actually have legislation in New York that's active right now, is to change the continuing medical education requirements. It would make New York the first state that would require all medical professionals to take CME, a CME course on SOGI, on HIV literacy, on sexual health literacy. It's pretty clear from a lot of data out there that there are late HIV diagnoses. There are concurrent HIV/AIDS diagnoses. There are people who are not caught early enough. And the suggestion there is that providers aren't comfortable talking about sex and health with their patients. They're making assumptions about the kinds of sexual activity that a patient might have. There's lots of reporting about providers feeling uncomfortable talking to trans and gender nonconforming patients, don't know how to even speak to their patients. So we're really excited about this idea. So my first question is, would PACHA consider at a future meeting perhaps working on this issue, perhaps via resolution, on the need on guidance for continuing medical education on sexual health literacy, on HIV literacy for all medical providers, working with federal partners both here presently and other federal partners. So that's my first question. And my second question, it's much shorter, so I promise I will give up the microphone. Has PACHA weighed in at all so far about the proposal that was on the Federal Register, I think on behalf of HHS and OIDP, around creating a federal database of people who are serviced by the Ready Set Prep program? There were, I can tell you that there was a lot of concern at that proposal on the community level. So I'm just curious if PACHA's had a chance to weigh in on that, hear concerns, and address them. Thank you.
So thank you for your question. And while you have the microphone, will you tell everyone, we use a lot of acronyms in public health? Where do you work?
I work at CHLP. The reason I use the acronym is because we are actually in the process of dropping the name. We used to be the Center for HIV Law and Policy. A lot of you might know us for our resources and legal and policy analysis on HIV criminalization. So we used to be the Center for HIV Law and Policy. We're doing what I think a lot of folks do, and they just do the acronym thing. But
thank you. And thank you for your questions. I can't speak to all of it, but, and I see John is off of mute as well. I can say that certainly we'll consider those recommendations, and this could be a great opportunity for your organization to reach out to local community advocates. I always say that language is both fluid and it's regional, and so there's some terminology that folks in New York would be of great benefit sharing with providers in New York that may translate very differently in Atlanta or in Washington, D.C. So that could be a great opportunity to bring in some community partners.
sometimes these aren't clear, but PACHA's ability
We could not hear a word they were saying.
So I was going to just ask Kay to just take a minute, if she could, to talk about, as a federal advisory committee, there are certain things we can comment on and certain things we can't. Sometimes things that are in the, up for public comment as an advisory committee. They're not always that clear necessarily to me, and sometimes we have to research these, but is there a couple sentences you can say about federal advisory committees and our ability to work in that space?
Sure, absolutely, John. A couple of quick things with PACHA. If we look at our charter, PACHA advises the secretary. That's sort of the bottom line. We get that question often, like, can you tell the Department of Justice X? And can PACHA tell another department? PACHA advises the Secretary of HHS, and those recommendations then go off to our colleagues at the White House, Director Phillips. So that's how we communicate. We don't provide advice and counsel directly to the President of the United States or other agencies. In regards to what PACHA can and cannot do, PACHA does resolutions, it does letters to the Secretary, and provides advice and counsel in that regard. If there's a proposed rule, for example, or things going on of that nature, PACHA does not come out with the statement. The department is not going to comment. The department will hear comments, and that is standard. But as far as an official response, if there's a public comment period, individuals provide comment, and that has happened very often with things that are in public comment space. Individuals as organizations, but as PACHA doesn't provide one collective response to a sort of a Federal Register notice per se.
Thank you very much, Kay.
Sure. If that's helpful. Does that get exactly what you need, John? Sure.
Yeah, I'm glad this issue of Ready, Set, Prep data collection proposed rule was raised, and I would like to be briefed, and I think the rest of the council, maybe we can do it at a ending the HIV epidemic subcommittee. I didn't know anything about it, and it was kind of a surprise when I learned about it. And so I would be interested, and I know the public comment period has closed, but we could be briefed on it and, discuss amongst ourselves. But I would like to thank you for bringing that issue, and I would like to recommend to the subcommittee that we get a briefing on it.
Our co-chair is that, so sounds like it can happen.
Sounds like a new agenda item. Yes.
Thank you for that. Just as a brief follow up, there was a joint public comment released by Prep for All, CHLP, PWN USA, and I'm forgetting, I think, another partner. I can't remember the other partner. I can make that public comment. I'm sorry, was it the caucus? Yeah, I can make that public comment on the HHS OADP proposal on the Ready, Set, Prep database available to maybe Caroline, and might be able to circulate it with the council. Yeah.
Meantime, we'll go virtually. I know the order keeps changing on the screen, but I'm going to go with what I wrote. I'll go. We have Gordella Lyon and then Michael Chaunsley.
Hi, thank you. My comment was about Ready, Set, Prep, and I know the previous speaker just referenced it, but I do think there needs to be a relaunch for Ready, Set, Prep. It has not reached the communities that need it or the providers who could really help patients who could see the value of PrEP. I'm talking about internal medicine providers, OB-GYNs, and asking that they also make it into probably a 5-step program, because many people think they cannot afford PrEP. and some providers think that PrEP has to be prescribed from an HIV care facility. They do not need to be an HIV care provider to prescribe PrEP, but somehow that message has not gotten out to the wider community. And we do see where a lot of people are not getting access to that valuable resource. Thank you.
They're clapping in the room for you, Cordell, in that comment. This is Marlene. Good to see you.
Hi.
My native Texan. Just wanted to say hello.
Hello. Yeah, thank you.
You're up next.
Hello, can you hear me?
Yes, we can hear you.
Okay, just one question. Will advocates get a chance to provide meaningful comment on CDC plans to initiate a national PrEP program? And how does CDC plan to respond to community calls for cost of labs and meds to be addressed with CDC funds?
I think that what we will do as a PACHA advisory council is take that question specifically back to leadership at HHS to determine what next steps may be in play. I saw that wasn't discussed in great detail when we had the federal panel share their EHE updates today. I think there's a lot still in planning, and I know there's a lot of community call into CDC to have some concrete answers or influence about what that potential program will look like. But I can say that we will certainly continue to have the National PrEP program on our radar, and our co-chairs for the Ending the HIV Epidemic subcommittee has been continuously working on staying abreast of the latest updates and being able to provide updates to the rest of the council. So it's on our radar. That's all I wanted to chime in. Carl, I didn't know if you wanted to add anything else to that, but thank you for raising that issue.
And for those in the room who don't know, Michael is an amazing PrEP warrior, really across the country. And happy belated birthday, Michael.
Thank you.
We have a question in the gallery.
Hi, this is Doug Rose. I'm sorry to be kind of a one-trick pony, and this may be way too granular for this discussion, but I'm wondering, there was a lot of talk about evaluating programs and program effectiveness and collecting data about that sort of thing. Is anybody evaluating the effectiveness of MHS versus traditional ways of monitoring disease? And, you know, does anybody know? I've been asking around all over the place. I'm like, aren't there any studies that say, oh yes, MHS is better because, and they don't exist as far as I can tell. And we keep getting these statements from people like the CDC that say, oh, but you know, these MHS programs really help us understand communities and what their needs are. But what they presented today were things like, oh, they discovered in Texas that the Latin community has a lot of problem with HIV, so we directed our funds. Why didn't they know that before, first of all? And what did MHS add to that? I'm really, you know, I feel like we're being sold a bum bag of dope, to excuse the expression. And, you know, really the goal is just to collect everybody's names and everybody's DNA. We went through this with names reporting all those years ago. I was involved with that too. Oh, we've got to collect people's names. We need to know who has HIV in order to, this is the only way we're going to solve the AIDS crisis. Well, now we have these huge databases with lots of names, and it has not, over 20 years, solved the AIDS crisis. So this is, I find it highly suspect that we want to start collecting DNA data and that it will somehow lead us to the solution for the AIDS crisis. That's my question comment.
Thank you. I will share for those who were able to attend either virtually in person for our Atlanta PACHA-to-the-People, which was last year. Those of us who were able to share, both in the gallery, members of PACHA, those who were joining in virtually, made our positions very, very clear. Thank you. Thank you. So are there
Yeah, we
questions?
have two more online, Lionel Hillard and then Jeff Taylor.
And in the queue also, we have two questions from the audience as well.
Perfect.
Yes, how you doing? My name is Lionel Hillard from Dallas, Texas. I have several concerns. I'm gonna start off with the PrEP, Ready Set PrEP. My concern is that we're dispensing this PrEP as if it's an aspirin, and when you have private sector doctors that's dispensing it, they're not following up with the labs and giving the people the individual proper care. So if you dispense medication and you don't give the ongoing coming back every 3 months or 6 months, or talk to them about STDs or ATI, you're losing there. And then the stigma around PrEP, whereas you're telling all the advertising with PrEP is telling it's a gay disease, and it's not. And then my other concern was the young lady was talking about aging. Primarily, she was talking primarily about aging, how she's getting the symptoms of somebody that may be 60 or 70 years old. We need to do more research on the younger generation that was born with it or has had it 30 years, and they're like 25, 30, say 35 years old or 40, and they're having symptoms of people who are 60 or 70 years old. We too often use HIV and aging as an old individual disease. This process has been around for a long period of time. We need to start looking at it inclusively of everyone, and not just. And for the record, I'm 63, so I just want to make sure that we set the next generation up so that when we fall off, they can follow and fight like we are. Thank you.
Thank you for your comment.
Jeff Taylor, you're next, and then we'll move it back to the room.
Great, thank you. Yeah, my comments are on aging as well. There's really not much research happening, and it's not being funded. Both Lionel and I serve in the ACTG, and we've been fighting for years to get them to do intervention studies for people living with HIV, and we're told that they cannot do it because it's not considered an infectious disease, and researchers are left going from institute to institute, kind of hat in hand, begging for funding. There's nothing dedicated for HIV aging research. And, we need to keep in mind that it's already more than half of people living with HIV, over 500,000 people, are already over age 50, which is when aging comorbidities start happening in people with HIV. And it's only going to get worse. It's just the tip of the iceberg, and we are way behind the 8 ball in addressing this. And I know that we've addressed this body and many others in the past and have yet to see any substantive funding go towards research. And then service implementation is the other issue. We need geriatric models in our Ryan White and FQHC clinics so that people get the appropriate screenings at the appropriate time, and they're not kind of lumped in with the general population, not getting things until after they're 65. It starts 10 to 15 years earlier in people with HIV, and we're seeing a lot of health and comorbidities in people as a result. We're really failing this population, and I would urge the PACHA and the relevant bodies to start, paying attention to this issue and acting, and not just providing words. Thank you.
So I have a question that came from the audience, and it says, what will CDC do differently with respect to MHS as a result of PACHA's resolution? So again, it gives us more items to add to our discussion. And so I thank the person who put this question out to us. Thank you.
Thank you very much.
I just make a comment that I know our CDC colleague is not at the table. So PACHA can certainly put that on sort of the parking lot.
Wonderful. And while you're off microphone, perhaps you can give some similar guidance for this one.
All right.
Yet another question from the audience. Please keep them coming. We have more. May I? Great. So when will the president move forward with SEC 1557? Section 1557, non-discrimination.
The non-discrimination.
It's the non-discrimination, yes.
The department is still working on that, so I don't have any additional information this time.
Thank you very much. And thank you, Martha. And thank you, Shakina.
No problem. So when you talked about anal cancer for men, I just wanted to please add for women, all genders. Yes, gender diverse, please. And then I wanted to talk about, since we've been talking a lot about PrEP, and I don't think anybody has talked about status neutral, which is also an intervention by CDC. Now, on the one hand, I worked, for a PrEP program in DC, wards 8-6 over there. And it was really critical that the people who were being provided PrEP were getting almost the same amount of service in terms of case management. They're facing, the only thing that differentiates them is the status, right? They're facing the same disparities, same issue. Slap on any heat map of any kind of issue, violence, disease, whatever, it's the same areas. So it's really important, when I hear that PrEP is just being dispersed everywhere and anyhow, you've got to consider this equity issue and geographic issue in terms of social determinants of health, and that people need more support with other things, even for the PrEP pill. The same way we've needed support for an HIV pill is the same. They need transportation to get that out. They need all these other issues. So I think the critical thing just to note that has been of concern to the HIV community is that whenever there's a status neutral intervention, that HIV funds are not being used to service. I'm sure CDC and EHE has tons of money to do that, but that especially in places where there's concern in rural areas, there's hardly any prevention funding. And so it seems like they're trying to stretch the HIV dollars to do, to support even people who may need prevention services. So just to flag that, that status neutral, could be great, especially, in serving people with, disparities and in terms of health equity. But I think the underlying issue is funding.
Thank you. Again,
can I just check the understanding of this since I'm writing the note? So, status neutral, the folks who are receiving services like PrEP also need kind of the case management support. But I think I'm also hearing like that's taking dollars away from people with HIV, and we need, or am I understanding this right? And we need more. I just want to make sure I capture this right.
Potentially, yes. We have not gotten a clear answer from CDC, who's not here, we understand, about, especially in places where there is no prevention funding, rural areas and so on and so forth, or perhaps in other places. They're calling it braiding of funding, so Ryan White prevention, and there's a term that is being used. We heard it actually from her, so from Laura Chiva, about braiding of funding. But if there's no funding to braid, meaning if there's no other sources of funding and there's only Ryan White funding, but they're trying to help that community in terms of the people who are positive and the people who may be at risk, then how are they doing that? And we have not gotten that, affirmation. So.
Yeah, and I wanted to add on to that response, and I think I heard similar questions in one of the public commenters as well about the use of status neutral in terms of the splitting and bifurcation of funding, quite frankly. And I think in many cases, we would all agree that what we're really talking about is needing additional resources to support people who may be vulnerable to acquiring HIV, not dividing the pot of existing resources. And I do hear that concern loud and clear. I did want to say I really appreciated some of the language that I think it was you, Kristen, that included in your presentation about the NOFO language that allows the ability for programs if they're able to achieve that, but I just like the intentionality of your language that spoke to whether or not it's feasible, whether or not there are enough resources to do it. I mean, really being frank about, and I think most implementers are trying to be considerate about the real use of limited dollars, but I think you and the other public commenter raising that question really puts it on the radar that we're not talking about diverting existing resources. We really need, if you're going to have a support arm for a status neutral approach, and I think obviously there needs to be one, we're talking about additional resources.
Ok, yo estaba leyendo un poquito la resolución y aquí yo veo algo como los ejemplos de la CDR y la MHS para elevar la salud equitativa. Estoy viendo particularmente del área de Atlanta y me causó como un poquito de curiosidad esta parte donde dice que esa data fue mostrada para la transmisión de VIH a través de la población hispana, latina, gay y bisexual, pero ¿están incluyendo a las personas trans en esas estadísticas?
So she says that looking at this presentation, which I believe she might have, yes, the resolution. She says that she has some concerns, especially on the CDR MHS slide, specifically concerning the molecular data showing rapid HIV transmission among Hispanic and Latino gay and bisexual men. Y quiere saber si hay también los trans comunidad. And she wants to know if the trans communities included this or if it's at least trans men are included in this statement throughout the resolution.
During CROI this year, Dr. Monica Gandhi spoke around how to meet people where they're at in terms of PrEP. And, you know, she advocated for mobile units. You know, we have so many states that are banning both youth and, you know, I wouldn't be surprised if we see an attempt to ban adult. I don't know that it's possible, but I don't see them trying to stop that. What is there a possibility that, you know, kind of piggybacking on her ideology, meeting people where they're at, you know, folks in Tennessee, I mean, the state has sent back 9 point how many million saying we don't need it. So, you know, for trans folks living in Tennessee, I mean, talk about uprooting your life. And, you know, I'm just wondering if we could maybe have adjacent states or, you know, I think someone spoke about having an underground railroad. Well, you know, maybe a mobile unit would do. I don't know. Thoughts?
Thank you. We're going to go online to Nana Khanna.
Thank you so much. I just wanted to follow up on a couple of things. One is I really appreciate the council for holding these PACHA-to-the-People sessions and the intent behind that of really involving and engaging with the community more deeply. I think that another way to amplify that commitment would be to look at how language justice can be integrated into both public comment periods and PACHA-to-the-People. So specifically, for example, making sure that there is ample time, if there's going to be consecutive translation for people to be interpreted and translated, having interpreters on site. Also within the context of a Zoom space, it is possible also to do interpretation on Zoom to make sure that there can be opportunities for folks who are not, fully bilingual in Spanish and English to participate in understanding the whole conversation. So I just wanted to lift that up as another opportunity to increase access and the intent around addressing inequities. The other thing I wanted to follow up on is the comments about status neutral. Thanks so much for uplifting that again, Martha, and to Marlene also for, layering on that concern. I want to be clear that part of what we're asking for, we're not just asking to look at the money and the resources. We are asking for what PACHA can do to hold federal agencies accountable and programs and jurisdictions and clinics and other providers being funded to do status neutral services, which we think may present a great opportunity to actually report and monitor and evaluate on exact units of service and the impact that that is having on services for people living with HIV. So very specifically, if status neutral housing is on the table, what is the change in the number of beds available to people living with HIV? If status neutral case management is becoming available, what is the change in the units of service, the actual hours of case management available to people living with HIV in that jurisdiction? We need to really understand that to understand the impact that these changes are having. So that's the level of monitoring and evaluation that we would like to see, in addition to just the dollars. We have to be able to track what the actual impact is. Thank you.
Okay, do we have anyone else online? Anyone else from the audience have a question? We have time, I guess, for one more. Going once, going twice.
I can spell it. Okay, go, no, I'll let you.
Yeah. Go ahead, Martha. Martha, bring us home.
I was just going to add sort of one final suggestion for the breast and chest feeding, and that, in a similar way, we've been advocating for sort of employment services to become part of sort of non-medical case management for people living with HIV, right? And it's the same way I would like to request, this information that was put in the guidelines to be made a part of, non-medical medical case management, and maybe in relation to what Amir was saying, I think it's almost like we do need continuing education for all these new things that are presented so that doctors can know. I mean, one of the things we were hoping to do is go to AIDS education training centers where we feel like they provide that forum. But I think, having heard Amir's comment, it would be good to just think of every time there's a new guideline or an issue that there's some sort of continuing education or mandate for our providers to be aware of what's going on. Thank you.
Well, we got So again, thank you all, and I'm going to pass the baton to Marlene.
And again, we do have opportunity for individuals to give additional comments before we leave the room today. If you really want to add something to some of the flip chart, we do take these papers back. We make notes, we review them and consider them. So please, as we close out the day, if you want to add something else as we take our seats, please feel free to do that. And just incredible work by you all out in the field, out in community. Your advocacy for what your communities needs is not unnoted. So just big thanks, big appreciation for all that you do and for spending your time with us today and considering PACHA important enough to hear your voice and hear your concerns. So we appreciate you. And please give a round of applause to Tori and Ada. And my co-note taker, John. And we'll give closing comments. Thank you.
Hello?
Go for it, Cordella. I think they missed you.
Oh, I don't know. I don't know if they can hear me.
I can hear you.
Okay. Thank you. Thank you. My comment is for more comprehensive and inclusive funding for HIV and STI testing. It is absurd that there are places that are funded for STI testing and they have no funding for HIV testing, or the flip occurs. And I think that's leaving a lot of people undiagnosed, and it is further limiting access to care that so many people need, particularly as, you know, they go through the struggles of making that one stop for care and are not able to get the comprehensive services that they need. So both must go together, HIV and STI testing. Thank you.
Great. I just wanted to give a quick thank you to my team here. They've been here. They've done incredible work. I have to start with my alternate designated official, Caroline Talib, who makes it happen. And I also want to thank Chloe, who was in the room and translating. I want to thank Chloe. She's a fellow. Yes, she's a fellow on our PACHA team, but she's a fellow on the PACHA team as well. So thank you, Chloe. Miguel, HIV.gov. Miguel is everywhere. Thank you for all that you do. And I want to thank the HIV team here. We have Emily. You guys know Emily, Nellie, Marissa was here, and Stephen, who is an ORISE fellow. Stephen, please stand. Who's just started, hit the ground running, doing phenomenal work. And I want to acknowledge Sharonda in my office, who's our operations director. She really does make things happen. And a new face, Renee Wilson. If Renee will stand in the back. Renee is on our team and works across the board, but one of her many talents is she's worked in local radio. So this is a face and voice you may hear more of, because I'm pulling her in to do some work with Miguel. And so when you hear her voice, you'll be like, why are we up here talking? So I just wanted to acknowledge so you will hear and see more of her. And so I turn it back over to John and Marlene.
I just want to say thanks, everyone. We appreciate your engagement and being here. Marlene's going to wrap us up. We'll be back here tomorrow at 9 in the morning. Remember, come a bit early to get through security lines if you want to be here right at opening remarks. And a reminder that we are still taking public comments, and we do have our next meeting scheduled. Arizona at the end of June will be September 19th, 20th virtual, and December 5th through the 7th will be in Houston. There you go. So really appreciate you. Marlene gets to bring her home.
Let's bring it home. Just want to remind PACHA members, if you can stay after the meeting for a few minutes to take a quick picture. Miguel and the team wants to capture us, so we have more images on the website. And just wanted to acknowledge what a productive day it's been, and really hearing very clearly, both from PACHA members around the table, as well as from the community members who engaged with us, particularly from Vincent and Dr. Stewart around the charge to have some deeper discussions around the impacts of racism in our work. So we're going to take that very seriously. Just want to make sure that we send our thanks to Kay and the team at HHS. And the guys who are quite frankly invisible most of the time, but make this work seamless and smooth. So all the technical teams and the staff with Rosalie and Associates, HHS Studios, all who helped to make this a resounding success. Thank you all. We are adjourned. Good night and see you tomorrow.
Produced by the U.S. Department of Health and Human Services.